Welcome everyone. So my name is Matt Shahini, and thanks everyone for joining. It's pretty amazing. We already have over 55 people participating, so it's great to see everyone. And it looks like we have people participating from across the world. So let's get started. So if you haven't already, you can go to this Poll Everywhere site, and you can click to see where we're joining from. And so we'll go back to the end for everyone's coming. So let's get started. So here's our first case here. Oh, I should mention that the group chat here, if you have any questions or you have any technical issues, please put anything here, and then we can chat about it. And I've muted everyone's microphone just because it can be a bit noisy if we have everyone on. So if you have any questions or you want me to address anything, please feel free to use the group chat. Okay, so our first case here, we have some surgical wedge biopsies. And you can see at low power, these are relatively diffuse process going on here. And then when we zoom in, we see this abnormality. So the alveolar septa are quite thickened, and they're thickened because of this fibroblastic proliferation. It's very loose fibroblastic proliferation. We also see these structures here, these eosinophilic hyaline membrane. Sorry, someone in the comments mentioned that they can't hear the audio. Can someone let me know if they can hear the audio? Okay, the audio seems to be working. Okay, great, thank you. So these eosinophilic structures kind of lining these alveolar spaces. And then we also have these kind of more cuboidal cells, these reactive appearing type 2 pneumocytes. Yes, everyone is on mute. And then we also have a fibrin thrombi here as well. So what do you think for this case is? What do you think the best diagnosis is for this case? A non-specific interstitial pneumonia, A, B, usual interstitial pneumonia, or C, a diffuse alveolar damage, or D, organizing pneumonia? It seems like people in the group chat are saying C. If you want, you can actually go to this Poll Everywhere site and you can put your answers in here as well. So it looks like we're getting quite a few responses here. And yes, so everyone got it right. So this is in fact a case of a diffuse alveolar damage. Let's just go back to it and we can look at some of the key features of it. So the first thing with the diffuse alveolar damage is the diffuse aspect of it is actually a little bit of a misnomer because you can get some patchiness of it. And what the diffuse nature essentially means is that it involves all components of the pulmonary lobule. And so it occurs over a spectrum of a time course. The first thing you're going to start to see is some edema in these alveolar septa, which then eventually will start to produce this more fibroblastic proliferation. And then we start to see these eosinophilic hyaline membrane structures. So there's a question about the Poll Everywhere. You don't need to download anything. You should just be able to navigate to that website and you should be able to answer the polls. And then as it progresses, you start to lose these eosinophilic hyaline structures, which we'll talk a little bit more in a bit. And then you can often just have really just remaining this kind of loose fibroblastic proliferation with these type 2 pneumocyte hyperplasia. And then fibrin thrombi are often seen in the later aspect of the course of disease. This is the histologic equivalent of an ARDS, or acute respiratory distress syndrome. Perfect. So, so the next question here is what features are we seeing here? How would you characterize it? And I've kind of alluded to them a few times as we've been going through it. These eosinophilic structures that are kind of lining these alveolar spaces. What's the best name for these? Is it A, fibroblastic foci? Is it B, edema? Is it C, hyaline membranes? Or is it D, fibroblastic plugs? Perfect, great job, everyone. So these are, in fact, hyaline membranes. So these eosinophilic hyaline membranes that are classic features of a diffuse alveolar damage process. Some people actually describe these as it looks like someone's taken some toothpaste and kind of smeared it along the inside of the alveolar walls. And if you imagine some nice pink toothpaste kind of smearing along here, so this is a characteristic feature of it that you see more in the early aspect of diffuse alveolar damage. These can often be quite rare because often when we'll get biopsies of these, they'll be later on in the disease course and these may have already resolved. Good job. Okay, so next polling question, which of the following is not a cause of diffuse alveolar damage? Is it A, inhalational injury? Is it B, vaping? Is it C, infection? Is it D, aspiration? Or is it E, all are causes of diffuse alveolar damage? Getting lots of responses. Perfect. So in fact, yes, these are all causes of diffuse alveolar damage. So you can have inhalational injuries. Vaping can be a cause of acute lung injury, including diffuse alveolar damage. Infectious etiologies, including both viral infections, bacterial and fungal infections, and aspiration can also be a potential cause. And that's why it's important for pathologists to actually polarize the slide to look for foreign material. So these are in fact all causes of diffuse alveolar damage. And the main role of the pathologist in this case is not only making the diagnosis, but looking for features that might indicate to the clinicians a potential etiology, such as finding features of infection or aspiration. So next question is, what is the cause of acute lung injury in this case, if you had this image here, where we have these cells that have both some nuclear inclusions as well as some cytoplasmic inclusions? Would it be A, CMV? Would it be B, HSV? Would it be C, HIV? Or would it be D, influenza? Perfect. Yes. So this is a case of CMV. And so this is what you're hunting for in these cases. You want to see these cells with this characteristic viral cytopathic effects where you have both these nuclear as well as cytoplasmic inclusions. And so you should have a pretty low threshold in these cases for doing ancillary testing, such as immunohistochemistry, to demonstrate CMV infection in these cases, because it can be quite important and help the clinicians get something to treat in these cases. What about this case? So if we did this is a GMS histochemical stain here. So if we did this on the case, we saw some more frothy exudates within the alveolar spaces. What would be the cause of the acute lung injury in this case? Would it be A, histoplasmosis? Would it be B, pneumocystis? Would it be C, blastomyces? Would it be D, coccidiomycosis? Seems like I'm getting a few different things in the group chat. Let's see what people are thinking on the polymer. Perfect. So yeah, so the majority is right. So this is a case of pneumocystis. So these characteristically have this frothy exudate within the alveolar spaces. And then these are the fungal organisms that you see here. They often can be likened to crushed ping pong balls, where if you take one of those white ping pong balls and you were to crush it, a lot of these have that appearance to them. I've also heard helmet shaped, but yeah, so this is a case of a pneumocystis. Perfect. Okay, so moving on. Before we move on, is there any questions about our first case of diffuse alveolar damage? If you have any, please just put it in the chat, and we'll keep forging ahead. The next case, we have another surgical wedge biopsy here, and you can see we have a relatively localized abnormality. So when we look down at higher power, we see some areas of largely normal lung. As we move over, we can see an area of abnormality. When we zoom down a little bit closer, we see that the abnormality is really within the air spaces, whereas the septa are actually quite normal looking. They're nice, relatively thin, without really any significant expansion in contrast to our previous case of diffuse alveolar damage. In this case, we have these proliferating fibroblasts appearing structures within these alveolar spaces, and they're often described as so-called mucopolysaccharide rich, because they have this appearance of that they're kind of rich in mucopolysaccharides with these clearing. And we also have some foamy macrophages that were often seen and associated with it. And in the interstitium, there's a bit of inflammation in there as well within the septa. And then these proliferating fibroblasts often have a dumbbell type of appearance, where you see it kind of it bulges out here, kind of narrows down and bulges out again as it kind of tracks through these alveolar spaces. And so we just back up to low power again, so you can see some more of these areas. And so this would typically appear as a ground glass opacity on imaging. And it's ground glass because there essentially would be less air within these alveolar spaces. because they're filled with these areas of proliferating fibroblasts. Perfect. So what do we think the best diagnosis is for this case? Is it A, diffuse alveolar damage? Is it B, organizing pneumonia? Is it C, acute and fibrinous organizing pneumonia? Or is it D, cicatricial organizing pneumonia? What does everyone think? Great work with Poll Everywhere. We're getting results quite quickly. Great. So yeah, so I agree. Great work. So this is in fact a case of an organizing pneumonia. The next question is, so these fibroblastic proliferations I was describing here, they have this mucopolysaccharide-rich appearance. What's the best term for this? Is it A, fibroblastic foci? Is it B, fibroblastic plugs? Is it C, granuloma? Or is it D, a fibrotic scar? Perfect, yeah, so these are fibroblastic plugs. And so this is an important point. So these are not fibroblastic foci. They are focal areas of fibroblast proliferation, but we really reserve this term fibroblastic foci for a usual interstitial pneumonia. In pulmonary pathology, we have a very specific use of this term. And so we really try to avoid the use of this term, except in cases of usual interstitial pneumonia. So the best term for these are fibroblastic plugs. And you can remember that because you have these proliferation of fibroblasts that are essentially plugging up these air spaces. So that's a good thing and a good teaching point for this case. So let's move on to our next case here. We have another surgical wedge resection. Oh, thanks for that point, Sanjay. So the fibroblastic plugs used to also be called Maslin bodies. So if you see that in some older textbooks or in a report, that's another name for a fibroblastic plug, is a Maslin body. Thanks for that. And so this case, once again, we have a relatively patchy process where we have some normal areas and then we have some abnormal areas here. I'm just going to move this other piece because I think it shows it a little bit better. And then when we zoom down here, we see that we have these alveolar spaces are where the abnormality is again. And instead of the proliferation fibroblasts, we actually have this more fibrin-rich structures, and they form these like ball-like structures within these alveolar spaces. But there also is a bit of organization to it. We do see some fibroblastic proliferation associated with this fibrin. What we're not seeing is we're not really seeing hyaline membranes, and we're not really seeing expansion of the alveolar septa by a fibroblastic proliferation or a lot of type 2 pneumocyte hyperplasia like we'd see in a diffuse alveolar damage. So it looks similar to our case of organizing pneumonia, but in this case, it's a bit more rich in fibrin. Let's see for the poll. What does people think? What does everyone think the best diagnosis is for this case? Is it A, organizing pneumonia? Is it B, acute fibrinous and organizing pneumonia, or AFOP? Is it C, diffuse alveolar damage, or DAD? Or is it D, cicatricial organizing pneumonia? Great, everyone got it. So this is a case of acute fibrinous and organizing pneumonia, or AFOP. And it's characterized by these more fibrin-rich balls that are present within alveolar spaces and does have a bit of organization with it as well. Great work. And so this is really the spectrum of acute lung injury. The way I think of it is that the lung only has a few ways in which it can respond to injury. And all the different etiologies essentially fall somewhere on this spectrum, where you have organizing pneumonia at one end, and then you have diffuse alveolar damage at the other. And acute fibrinous and organizing pneumonia fall somewhere in the middle. So the patients who have organizing pneumonia, these often present as ground glass opacities, and these patients can be doing quite well and are often seen more as an outpatient clinic. Whereas cases of diffuse alveolar damage, these patients essentially have acute respiratory distress syndrome, and these patients can be quite sick and have a very poor prognosis in some cases. And acute fibrinous and organizing pneumonia is somewhere in the middle, where some of these patients can have a more aggressive course, but other patients can do quite well. So one last case here in our spectrum of acute lung injury cases. So here, once again, we have a patchy process, and where we have this abnormality that's localized here. And once again, the abnormality is within the air spaces. And instead of this time having a more mucopolysaccharide-rich of these fibroblastic plugs or a lot of fibrin, we're seeing a lot more collagen deposition. The looks like it has a much more chronic appearance to it. And so this is actually a case of a more cicatricial organizing pneumonia that's been recently described. And so these are more cases of that have been kind of progressing over time and are resolving. And so not all organizing pneumonia will go away very quickly. Some of it can persist for some time, and it often has this more collagenous or fibrotic appearance to it. So I just wanted to show that as a case of cicatricial organizing pneumonia. Perfect. So that ends our series of acute lung injuries. I'm going to go into some other cases now. Does anyone have any questions as we move on to the next? Perfect. Okay. Okay, so our next case here. Oh, so we have a question. According to the spectrum model of understanding, do we sometimes see foci of less forms of acute injury? Yeah, so you can. That's a great question, Ariel. So you can actually have a spectrum of acute lung injury. So you can see areas of organizing pneumonia in areas. You can see areas of diffuse alveolar damage can be quite patchy. So that is a great question that you can see a spectrum across it. Thanks for that question. Okay, so our next case here. There we have open. Okay. So we have another surgical wedge biopsy, and we can see at low power that this is a quite abnormal specimen, where we have very little residual uninvolved lung. We have another point here from Sanjay. Thank you. So all fall under the umbrella of acute lung injury, so you get overlap. Thanks for that comment. So this case here, we have relatively quite abnormal piece of lung, but we do have a bit of normal lung down here. And then the first thing I want you to notice from low power is the distribution of disease, where we have the worst abnormalities just underneath the pleural surface here. So I've oriented where we have the pleura on top, and then this would be furthest away. So most of the abnormality is right underneath the pleura. Then we do have these patchy areas that are quite normal down here. So if we zoom down here, I'll just prove to you that these are nice areas of normal lung parenchyma. We have these nice thin alveolar septa. This is where gas exchange occurs. And then if we look over here, we have quite abnormal areas. So we have this dense fibrosis with these cystically dilated spaces stacking on top of each other that are lined by this metaplastic bronchial type epithelium. We can see some cilia to it. And then in other areas, we see more of an active proliferation of fibroblasts, as you can see here, that kind of proliferate and bulge into these air spaces. So we have a very heterogeneous process where we see different phases of disease in the same section, where we have uninvolved lung, we have densely fibrotic lung, and then we have some actively fibrosing lung in a single section. So what characteristics, I've given a bunch of features, what do you think best describes this diagnosis? Is it A, a UIP case? Is it B, a chronic hypersensitivity pneumonitis? Is it C, nonspecific interstitial pneumonia? Or is it D, diffuse alveolar damage? Great work. So this is a case of usual interstitial pneumonia, or UIP. And so just to review some of the features, we see a patchy process where we have areas of dense fibrotic change. We see these areas of cystically dilated spaces that have intervening areas of fibrosis, which we'll talk about in a little bit. And then we see also these more active areas of fibroblastic proliferation shown here. And it often has this subpleural distribution where it's worse around here, and it really gets better as you get towards the center of the specimen. Great work. Okay, so this high magnification picture here, which I've talked a bit about briefly, and I showed it. So what am I trying to show by this image here? Is this an example of a fibroblastic plug? Is this B, a fibroblastic foci or focus? Or C, is this a fibroblastotic scar? And lastly, or is this B, a granuloma? Great work. So this is, in fact, a fibroblastic foci, or this is a fibroblastic focus as a singular. And so this is where we use the term fibroblastic foci, is in the diagnosis of UIP. So just a reminder, we use fibroblastic plug in cases of organizing pneumonia, or a mast on body, as Dr. Mukhopadhyay highlighted in his comment. So fibroblastic foci is what we're seeing in this case here. Perfect. And so what am I trying to show by this image here? It's a little bit cut off, but I think we can see it enough, where we have these cystically dilated spaces with intervening fibrosis that are kind of stacking on top of each other. Is this A, microscopic honeycomb change? Is this B, bronchiectasis? Or is this C, a fibroelastotic scar? Perfect. Yeah, so in fact, this is correct. So this is a case of, this is some microscopic honeycomb change, where we see these cystically dilated spaces that are stacking on top of each other with this intervening areas of fibrosis. So bronchiectasis is when you have kind of expansion of an airway. So we can see here, this is the actual airway with its paired artery, which is actually a little bit enlarged, but relatively normal. And so it's in the differential of whether it's honeycomb change or bronchiectasis is a phenomenon. But when we start to see them stacking on top of each other, this is a microscopic honeycomb change. And this is an important part of the radiology as well. So when the radiologists are looking at the scan, if they see areas of honeycomb change, that will really help them make the diagnosis of the usual interstitial pneumonia. And so when we see it on the pathology slides, this can really help us make the diagnosis in that case. Thank you. Okay, so here's our next case. As it's opening, you can see it's a relatively uniform appearance throughout. Perfect. Okay, so we have a relatively uniform process. Some areas look a little bit busier than others, but that could just be a little bit of atelectasis. So when you process the specimens, they can sometimes collapse a little bit. And so you can help that by making sure they don't dry out and making sure they, when you're, sorry, I'm just refreshing it. This case here, just a bit out of focus. There we go. Okay, so we have a relatively uniform process where here's our interalveolar septa here. We can see that it's thickened, but it looks quite uniform as we go throughout it. And it's thickened by this more fibrotic process. Sorry, it's just having a little bit of trouble loading the slide here. Here we go. It looks a little bit more fibrotic, and it has some scattered inflammatory cells in it as well. And so this, when you first look at this, it reminds me a little bit of our case of diffuse alveolar damage, but in contrast here, we don't really have those proliferating fibroblasts. This has a much more fibrotic or collagenous type appearance to it. And we're not seeing the other features of acute lung injury in this case. And then if we go anywhere else, it really looks relatively uniform as we go throughout it, where we kind of have this uniform expansion of the septa as we move throughout. And then in contrast to our case of usual interstitial pneumonia, we're not really seeing big cystically dilated spaces or lots of architectural distortion. We're not really seeing temporal heterogeneity either. We're not really seeing fibroblastic foci or areas of normal lung. It really just is kind of almost a boring process where we have this really uniform expansion of septa. So in this case, what do you think the best diagnosis is? Is it A, UIP? Is it B, NSIP? Is it C, chronic HP? Or is it D, DAD? Perfect. So everyone got it. So this is in fact a case of a non-specific interstitial pneumonia, or NSIP. So these cases are characterized by uniform expansion of the alveolar septa. It's a very homogeneous process in contrast to our cases of UIP. Okay, so here's another case, which I think is a bit of a tricky one. So as we're zooming down, you see it's a really uniform process once again, where we have this diffuse abnormality of the interstitial septa, where we have this expansion by this process. It's relatively low cellularity. It looks a little bit funny for the fibrosis that we saw previously, not really collagen deposition or fibroblastic proliferation, but it has this more amorphous eosinophilic character to it here. Some of the vessels look a little bit funny too. You start to see this more eosinophilic deposition in some of these vessels as well as we move around. You can see here in this larger one, we have this kind of patchy areas of amorphous distribution in these vessels. And so I'm just going to zoom out to a little bit more power and go over here. And then we have this more nodular area with this similar deposition of this eosinophilic material that has a bit of this kind of cracking artifact to it as well that you can see. Yeah, so what do people think the best diagnosis is in this case? Is it A, NSIP? Is it B, amyloid? Or is it C, diffuse alveolar damage? Or is it D, organizing pneumonia? Perfect. Let's see what everyone thinks. Great. So that is in fact the answer. This is a case of amyloidosis. Great job. And so this is actually, so we did a Congo red histochemical stain because with digital slides they can't polarize. So I just took a video of it. So this is actually the Congo red histochemical stain under polarization. So this is just a video as I'm moving the polarizer around. And what I want you to notice is that the positive red Congo red staining goes from this red color to a yellow and a green color. And so that's what a positive Congo red staining should look like. A bit of a pitfall is that collagen will actually polarize, but it has a more of a white color to it. In this case, it has we see nicely goes from this yellow to green color. I just have a comment here from Dr. Mukhopadhyay. So before diagnosing fibrosing NSIP or even amyloidosis, always consider SRIF, far more common and very under-recognized. It's a great point. Thank you so much. So it really has this really collagenous appearance to it in smoking-related interstitial fibrosis, or SRIF. And it's a kind of an interstitial fibrosis that you can see in patients that have a smoking-related lung disease. And so the term is SRIF, smoking-related interstitial fibrosis. Thanks for the point. So another poll question here. So what's the most accurate way to determine the type of amyloid? Is it A, morphology? Is it B, IHC? Is it C, genetic testing? Or is it D, mass spectroscopy? Sorry, I should say mass spectrometry, but I think everyone gets the point. Let's see. Yeah, so it is D, mass spec. Great job. And so this is actually how the mass spec is done. So what happens is they'll do a Congo red stain here, and then what will happen then is these areas are then using a laser capture and microdissection will actually be lasered off, and then this material will then go through a mass spec, where then the fragments of the peptide can then be analyzed by the mass spec detector. Great. Another poll question here. So which of the following proteins are associated with amyloid? Is it A, light chain? Is it B, transthyretin? Is it C, prolactin? Or is it D, beta amyloid / APP? Or E, all have been associated with amyloid? Perfect. Great work, everyone. So these, all of them are associated with amyloid. So the case that I showed you is actually a case of light chain deposition. B, transthyretin. This is an important one to identify because a subset of these patients will actually have a genetic mutation that makes them more predisposed to amyloidosis. C, prolactin you can also get, and B, beta amyloid / APP is typically what you see in the brain as well. Great work. So another question here, what type of amyloid is most likely to be associated with systemic disease? So not just within the lung, but throughout the whole body. Is it A, nodular amyloidosis? Is it B, septal amyloidosis? Or is it C, trachobronchial amyloidosis? Okay, great. So I think this is a teaching point here. So nodular amyloidosis and both tracheobronchial amyloidosis are usually a localized process, whereas if you start to see the amyloid within the septa or septal amyloidosis, which is the case of, it's almost always a systemic disease where you have amyloid deposition in other organs. And typically the lung is not the presenting symptom. Often they present with other features of amyloid or amyloid deposition at other sites. And the lung is only identified secondarily. But in some cases, we do get it as an initial presentation. So that's an important point. If you see a case of nodular amyloidosis or tracheobronchial amyloidosis, these can often be localized processes. Great. Okay, so let's keep forging ahead. So here's our next case here. So we have another surgical. This is actually from an explant case. And so what I want you to notice here is that we once again have a patchy process on low power where we have these areas of normal lung, and then we have these areas of fibrotic lung. In this case, though, the distribution is really not subpleural. It seems to be really more around these airways where we're seeing these abnormalities. And so let's zoom into a little bit higher powers so what we can see. As you're screening across, you'll notice these areas of purple. So these are calcifications. This can be a highlight to areas of where you want to look down because often you can see some abnormalities of these calcifications. So as you're screening around at low power, if you see these calcifications, it's a good key to zoom into higher power like we're doing here. And so what we can see here is we see these multinucleated giant cells and that are associated with these calcifications. And then one of them actually has this, maybe someone in the chat can write what they think this structure is here in this multinucleated giant cell. What would the term for that be? It does look a little bit stellate. Is there another name for these? Yeah, asteroid bodies. Yeah, so just to show you that asteroid bodies are not specific for sarcoid. This is not a case of sarcoid. You can see asteroid bodies in any giant cell process. So we have these giant cells. They're relatively, so we're having these granulomas here that are relatively poorly formed. They have lots of lymphocytes associated with them. And then we have this fibrosis. It's really centered around these airways. And it's patchy, and so we move around where we see some more poorly formed granulomas around these airways here. Okay. So what are people thinking the best diagnosis is for this case? Is it A, usual interstitial pneumonia? Is it B, chronic hypersensitivity pneumonia? Is it C, nonspecific interstitial pneumonia? Or is it D, diffuse alveolar damage? Great work. So this is, in fact, a case of a chronic hypersensitivity pneumonitis or pneumonia. And so it's characterized by this patchy process that's often airway centered with these poorly formed granulomas and multinucleated giant cells. Okay, so the next question is, which of the following are causes of hypersensitivity pneumonia? Is it A, birds? Is it B, moldy hay? Is it C, humidifiers? Is it D, air conditioners? Is it E, down pillows? Or are all potential causes of hypersensitivity pneumonia? Great, yeah, so these are all causes of potential causes of hypersensitivity pneumonia. So there's a very long list of potential exposures that people can have. So it can range from they have a pet bird in their house, they could be a farmer and can be exposed to moldy hay. There's something called humidifier lung, where you can get certain thermophilic bacteria growing in humidifiers or air conditioners. And yeah, so it's a great point. Most patients have no history of exposures, and it can be quite challenging to find that. So we, as pathologists, have an important role in this diagnosis as we identify these features. We can raise this in the possibility, and they can look for these because they can be subtle, the potential exposure, such as they might have a down pillow or down comforter that can be causing it. And they can clinically try and remove these exposures for these patients. Okay, so let's keep forging on. So we have another case here. We have some cryobiopsies in this case. And so we see there's patchy abnormality here as well. And so we're seeing these granulomas again. They're a little bit better formed than what we saw in our previous case. And some of them actually seem to be a bit more in the air spaces than in the septa. So we have some more here with these multinucleated giant cells, these granulomas. And as I mentioned, they're a little bit better formed. We see a nice multinucleated giant cell here. And these are really kind of packing within these air spaces. So it's a bit of a trickier one. So what do you think this patient likely has? Do they have an A, bird, B, farm, C, hot tub, or D, coal mine? I guess it'd be kind of hard to have a coal mine in your house, but never know. What does everyone think that's causing this case with these granulomas? That's a good question, Ari. I'll go back to you in a second about how we know these are air spaces and not interstitial. Okay, so yeah, so I think people are thinking this could be another case of a chronic HP case. This is actually a case of hot tub lung, which is actually from exposure to mycobacterial bacteria that can be present in these hot tubs. And you often see a bit more, it's not, the features aren't completely classic, but they can be supportive of that. And what you really see is these better formed granulomas that almost have the appearance of a sarcoid look, but instead of being within the interstitium, they're actually in the alveolar spaces. So Ariel had asked how do you know whether they're in the air spaces or the interstitium? It's going to be a bit challenging. It's something I struggle with a little bit, but something that you can look at the contours. This has this more rounded appearance to it. And then you can see the alveolar septa kind of lining on the outside here. So this kind of helps me to say that this is more of an airspace process. And so this is the highlights the importance of taking good histories in these cases. In that this patient did have a hot tub, and it was so this is a case of hot tub lung secondary to exposure from the mycobacterial infection. And so it's typically associated with indoor hot tubs because it's more of an enclosed environment than outdoor hot tubs. Great. So another case here. So on low power, you'll notice it has this very blue character to it, almost has this geographic appearance to it. As we follow along, so the slide's ready here. As we zoom down we can once again see this really blue character to it, and it's blue because we have a lot of necrosis, and we have this acute inflammatory cell infiltrates from the nuclear debris from these dying neutrophils. I'm just going to turn it this way. You can see, and then we have big areas of necrosis here. Yeah, it is a very impressive case, Ariel. Thanks. And then we do have these focal granulomas here, so we can see a multinucleated giant cell. This multinucleated giant cell has a bit of a characteristic appearance where it's very hyperchromatic, and we have these nuclei all lining along one side. That can be a bit of a clue for the diagnosis in this case. And the other clue is the very blue process where we have this kind of more geographic necrosis. And then there's one more thing I'm hunting for. And then we have these vessels that have this necrosis of the wall, and we have these neutrophils going into the wall here as well. Okay, so what are people thinking the best diagnosis is for this case? Is it A, tuberculosis? Is it B, granulomatous with polyangiitis, or granulomatosis with polyangiitis, or is it C, aspiration, or is it D, chronic hypersensitivity, pneumonitis? Let's see what people are thinking. Great job. So this is in case of active GPA. The old name of this was Wegener's. And so it has the characteristic appearance of this really blue appearance at low power, has the hyperchromatic nuclei, the multinucleated giant cells. It has in areas of vasculitis. So if the patient underwent serological testing, which of the following would be characteristically elevated? Is it A, P ANCA, or is it B, C ANCA? Great job. So that is in fact the answer. Is it C ANCA would be positive in GPA. And then another question about it: what other organs could be classically involved in GPA? Is it nose and kidney? Is it B, brain and bones? Is it C, thyroid and mediastinum? And is it, or D, ears and trachea? Perfect. Yeah. So great job, everyone. And then someone actually brought up in the comments, I think it was Malad, something that I was going to bring up as well is the way you can remember the C ANCA as well as the nose and kidneys is if you pronounce Wegener's instead of Wegener's, it's Weckner's with a C in the middle. You can remember that as a C ANCA. And then if you were to draw a C over a person, the C would hit their nose, lungs, and then kidneys. And so Weckner's, if you mispronounce Wegener's, is the C ANCA, and then if you draw the C over a person, you get nose, kidneys, nose, lungs, and kidneys. Yeah, it was. I learned that when I was studying for my boards. It's a nice way to remember it. Okay, getting towards the end. Here's another case here. Perfect. Okay, and so we have once again have this patchy process where we have some normal lungs, and then we have these abnormalities here. It's kind of patchy, and then we see lots of multinucleated giant cells, and then we can see there's an appearance of this foreign material here, where some of it has this more cleared character to it, other has this more basophilic or purple character to it, and it's really patchy throughout the lung here. It's a quite exuberant example where we have lots of this material here all throughout. Oops. And then in one of these cases, it would be very important to polarize it. So if we polarize this, you see that some of it is quite birefringent when we polarize it. Some of it is not. And so if you look at the yellow arrow here, you can see this more purple appearing material does not polarize. Whereas this more colorless material, when we actually polarize it, it actually is quite birefringent here. It really shines. Okay, so what do you think this patient has a history of? Is it A, embolism of a tumor? Is it B, intravenous drug use? Is it C, he has some birth? Or you think D, he's also a guy who's got a hot tub? Great, so perfect, everyone got it. And Dr. Mukhopadhyay has highlighted a paper in the chat as well, so if anyone wants some information on this. This is actually a case of intravenous drug use. And so I just want to go back to this video here to show you, you can actually see there's actually two distinct components. And so these pill fillers, which are usually from crushed pill fragments of people who use intravenous drugs, actually can often have different fillers in them. And so in this case, we actually see two different types of pill fillers. So this more colorless material that then polarizes quite nicely is the microcrystalline cellulose, whereas this purple appearing color, the material that doesn't really polarize, is the crosspovidone. And that's the paper that Dr. Mukhopadhyay has highlighted. And I actually learned about how to recognize these different materials from a tutorial he did a few years ago on it. That was excellent and really teaches you how to differentiate between these different pill fillers. Great job. So that's it. That's 45 minutes. I think that's a time. So I thank you everyone for joining. It's been great. I'm amazed we actually have 100 participants, which was awesome. So if we can just end with, if you want to type into Poll Everywhere one thing that you learned today, hopefully I at least taught you one thing during the session. And yeah, and we'll hopefully I'll do some more in the future. Thank you everyone for joining.